Hello everyone, welcome to Chapter 2 in Comparative Health Information Management textbook. This is for the Alternate Care Systems course. Chapter 2 is going to cover our hospital-based care systems. For your freshman class, this is really going to be the first recorded lecture that you're going to have. So let me just tell you a little bit about how I do this. I take our PowerPoint, as you can see from the video, and I go through the textbook and point out a few other things that the PowerPoint does not. Definitely not covering the entire chapter, so don't expect to get every word of the content in this lecture. So essentially consider it as me covering the high points. I know some of you learn by hearing, so this is just another tool for you to use to be able to comprehend this information so that you can pass this test. So let's get started. If you want to follow along in the text, we're on page 28, again starting with hospital-based care. We're going to cover several different kind of care systems in this text, but we're going to start with hospital-based care. We are going to take a field trip to North Mississippi Medical Center, and we're going to tour the HIM department, so you get better feel for that hospital-based care. Not necessarily going to nursing units and things like that, but seeing the HIM side of things. All right, so we're going to skip over the learning objectives, and we're going to start on our first slide. And I really think they kind of misnamed this slide, definition of healthcare institution. I think it was supposed to be more definition of a hospital. But if you look at the bottom of page 29 under types of settings, it says a hospital is a healthcare institution that has an organized professional staff and medical staff and inpatient facilities, and which provides medical, nursing, and related services. So we have professional staff, medical staff, and then you're going to have your medical and your nursing and your other related services. And according to the AHA, which is the American Hospital Association, a hospital must maintain at least 6 inpatient beds and must be readily available for patients who stay an average of 24 hours or more per admission. Healthcare services provided to patients in a hospital can be categorized as either inpatient or outpatient. And so inpatient is going to be acute care or your short-term care, and your outpatient is your ambulatory care. So your inpatient services is going to consist of the healthcare services, room, board, the continuous nursing care that's provided, 24/7. You got people coming in and out of your room at early hours of the morning. People say they never can sleep in a hospital because someone's coming in every hour or two. And then your outpatient care is going to include the healthcare services provided in a hospital-based clinic or department that's not dedicated as an acute care unit. So an example of that would be like the wound care center. So if you're a patient in the hospital and you've got a wound, they may take you down to the inpatient or the wound care center, but that's not necessarily an inpatient department because you've got outpatients coming in to receive wound care as well. All right, then we also have emergency care and then observation services. We'll get a little bit more detailed into those as we continue. So we're going to move on down to the inpatient short-term acute care section on page 30. Inpatient short-term acute care is the type of care generally associated with hospitals. Patients who are in need of around-the-clock acute care are admitted as hospital inpatients upon the order of a physician. Hospitals may be general hospitals or they may be specialty hospitals, focusing on certain types of services, illnesses, or specific types of patients. Le Bonheur, St. Jude, these are pediatric hospitals, so those are specialty hospitals. Hospitals provide a comprehensive range of services to patients who are acutely ill. All right, let's skip down to hospital-based ambulatory care. And I'll tell you something that I really like about this textbook. is every one of your blue terms, your key terms, you're going to find that definition in that margin of the book. So that's really cool that you don't have to go search that definition out. So you can read the text, and then if you need, that text defined for you, then you've got that definition. So that's really nice. All right, so hospital-based ambulatory surgery began developing in hospitals during the 1970s and grew rapidly as years advanced because technology just let them do so much more surgery on that outpatient basis that, prior to that, you could only go to the hospital for that service. And then actually third-party payers reimburse certain surgical procedures only when performed in the ambulatory setting. So in some cases, you can't even go to the hospital and have a surgery because they say it's not inpatient. And I'm not saying you can't go to the hospital and have that surgery, but you're not going to have that as an inpatient. It's going to be an outpatient surgery. You're going to go home the same day you have surgery. All right, another type of ambulatory care that hospitals have provided since the late 1800s is the hospital clinic. And so early hospital clinics offered care for the poor, which also provided an educational experience for the physicians in training. An additional type of ambulatory service provided by hospitals is emergency care. Most hospitals have an organized emergency department with a wide range of services. The emergency department may be staffed as a trauma center, the first area in which your acutely ill patient is treated before they're hospitalized. But many patients use the emergency department as an ambulatory care service. So they use the ER as their physician office. If I was sick tonight, most likely I'm going to wait until tomorrow morning and go to an urgent care clinic or see if I can get an appointment with my physician. But some people don't wait and they just go to the emergency room. All right, so skipping over to page 31, that second paragraph there, one type of outpatient setting that largely resembles the inpatient setting is that of hospital observation services. Observation services may be provided in a regular inpatient unit or in a designated observation unit. So you could have a nurse who has patients in rooms 1, 2, 3, 4, and 5. And for her sake, she doesn't necessarily have to know, but patients, 1, 2, 3 could be inpatients, and page 4 and 5, or patients 4 and 5 could be observation patients. So the care doesn't necessarily change, and they can be, again, in one room to the next, inpatient, outpatient, but, typically that's how it is. Now, there are some facilities that do try to do observation units. I know North Mississippi Medical Center tried. They have a specific unit set aside for that. Not to say that observation patients don't end up on other floors, but they did try to limit that to one area within the hospital. All right, so we are going to go down to long-term care. Going down to the very bottom of that page, we're going to talk about our LTACs. You'll hear that term. So another type of hospital setting is the long-term care hospital, or LTCH, and that's where you get LTAC. A long-term care hospital can either be a freestanding facility or a hospital within a hospital. In the 1980s, the Medicare program defined the characteristics of LTAC facilities and exempted them from the original hospital inpatient prospective payment system. And by 1997, there were 195 LTACs in the United States. And by 2007, the number had grown to 396, more than doubling in a 10-year period. All right, so let's talk about the types of caregivers. Back up. The slides skip the different types of patients. So we're going to cover those patients really quick. So you have your hospital inpatient. This patient is acutely ill. They're treated in an area of the hospital where patients generally stay overnight. They could be admitted for a medical condition that can be managed without surgical intervention, or they may require surgery. And depending on the size and complexity of your hospital, different types of inpatients may be cared for in designated units. So if they're a cardiology patient, they may be on a heart floor. If they're a kidney patient, they could be on a nephrology floor. If they are a cancer patient, most of the time facilities will have, designated units for each different type of patient. And then your critically ill patients may be cared for in an ICU or intensive care unit. All right, so let's talk about our hospital outpatients. In general, a hospital outpatient is a patient who is evaluated or treated at a facility but is not admitted as an inpatient. So examples of these hospital outpatients are your clinic outpatients. They're treated in an organized clinic of the hospital in which the hospital staff members evaluate the patient and manage the patient's care. Then you've got referred hospital outpatients. This is an outpatient who is referred to the hospital for specific services. So if I go and see my physician, Dr. Walton, at a North Mississippi Medical Center clinic, and he wants me to have an MRI, he can't do that in his office. So he's going to send me to the hospital for an MRI. So that's a referred hospital outpatient. All right, and then you have your emergency outpatients. So again, these patients come into the hospital to the emergency room and get treated, and then they're sent home. All right, and then we talked about our LTACs. So you have your long-term care hospitals. Generally, these patients are acutely ill. They're more acutely ill than patients in other long-term care hospital settings. So they often are admitted from a short-stay hospital intensive care unit, and they have very complex medical conditions. They could have respiratory conditions, and they're dependent on a ventilator, or they're going to require, acute services. They could be cancer patients and need cancer treatment, or they may have had a traumatic brain injury, they're head trauma patients, or they're there for pain management. All right, so now we're going to go on to our types of caregivers. Still on page 33, slide 12. So just as there are many different types of hospital patients, many different types of caregivers participate in hospital care. Physicians from every specialty see patients both on an inpatient and an outpatient basis. Nurses provide nursing care to both inpatients and outpatients. And other health professionals such as physical therapists, occupational therapists, clinical laboratory scientists, and pharmacists, to name a few, which we could name a whole lot more. You've got dietitians, respiratory therapists, social workers, case managers, and whether they're not traditionally giving direct patient care, they're supporting the patient care of these other caregivers. One type of caregiver unique to the hospital setting is the hospitalist. We're moving kind of down into that section. A hospitalist is a physician who provides comprehensive care to hospitalized patients, but ordinarily does not see patients outside of the hospital. And so what that means is that physician does not work at a clinic. They do not schedule appointments to treat patients in that clinic setting. They strictly work for the hospital. You have your daytime hospitalist, who are usually on from 7A to 7P. And then you have what you'll hear called nocturnist. And these are your night shift hospitalists. And they typically work from 7P to 7A. At North Mississippi Medical Center, there's probably 20 to 25, not even sure how many hospitalists there are now. But they cover pretty much all the patients admitted to the hospital. I'd say they probably have at least 70% of the caseload. Sometimes less, it just depends. But some of those physicians I know at one time were rounding on, upwards of 25 to 35 patients a day. And that's in their 12-hour shift. So that's a lot of patients to see. And they do have help. They have physician assistants, and they have nurse practitioners that are on their team that are also helping and rounding on patients. So I wanted to point out that hospitalists you're going to find in your hospital settings. All right, so we're going to switch over to page 34, and we're going to talk about regulatory issues. Now, in health records last semester, we talked about licensure, accreditation, and things like that. So we're going to touch a little bit more on that. But let's go back and just kind of to validate this. Licensure is required. You must be licensed if it's required. So each hospital has to be licensed within the state they're located. So North Mississippi Medical Center is licensed by the state of Mississippi. Magnolia Regional Medical Center in Corinth is licensed by the state of Mississippi. Licensure requirements vary from state to state. So what's required in Mississippi may not be required in Alabama, may not be required in Texas, may not be required in Alaska. It's state by state. Now, we've talked about federal regulations. We talked about the conditions of participations for hospitals from CMS, CMS, and we talked about the different organizations that can give you that deemed status through their accreditation. So those are programs like Joint Commission, the Healthcare Facilities Accreditation Program, the American Osteopathic Association, National Integrated Accreditation of Healthcare Organizations, and DNV Healthcare. So these are the types of organizations that provide that deemed status. And remember, this is just a side note, but those organizations have to be surveyed by Medicare because they have to have their own deemed status before they can go out and start reviewing other facilities. All right, and then dropping down to accreditation. We talked about accreditation being voluntary, but is it really voluntary? No, not really. So hospitals voluntarily seek accreditation to demonstrate to their patients, to their communities, to insurers, to managed care organizations, and to others that their organizations are providing quality care. And we talked about Joint Commission being one of those facilities that you're accredited through. So you probably would much rather have Joint Commission come and survey your facility instead of CMS. So while we say accreditation is voluntary, it's sometimes it's the lesser of two evils. All right, so let's move down to documentation. Over on page 35, the fundamentals of good patient documentation are essential in the hospital setting. This is important not only to meet accrediting and regulatory guidelines, but also to provide high-quality care and to determine the appropriateness of payments to the hospital. The extent of documentation in the hospital record depends in part on the type of services rendered. For example, the records of a surgery patient, whether they're ambulatory, outpatient, or inpatient, typically include a history and physical, an op report, anesthesia records, post-operative recovery notes, and path reports if there was a specimen taken. Another example of how the nature of services affect the documentation is the extensive and detailed documentation required for patients who are treated in critical care units. Some hospital records, however, such as those of referred outpatients, contain minimal information, and it could just consist of the orders and the test result. So again, the type and extent of your documentation is going to depend on the services rendered. If they're a critical care patient, you're going to have pages and pages and pages of documentation. If they're a surgery patient, you should still have pages and pages and pages. If they're an outpatient, you may have 3 sheets of paper and a test result. If they're a maternity patient, you may have office records from the obstetrician saying how their care went along the whole pregnancy. So you've got different types of information, different types of documentation being captured based on the services performed. All right, an additional, and we're moving to page 36, the top section, an additional documentation element that must be obtained from a physician when a test is ordered is clinical information describing the reason for the test. So you've got to have the order for the test to be performed, but you've also got to have that clinical information giving the reason for the test. And you'll learn this as we go along in the program, but if the hospital lacks the information to demonstrate that the test was medically necessary, then they may not get paid. You're going to lose out on reimbursement if you're just doing a test just because you have an order from a physician. But if I go into the hospital or into a physician office and I have a broken foot and the doctor writes an order for me to have an x-ray of my chest, how is that medically necessary? If the only complaint I have is I think my foot's broke. There's no reason at all for me to have a chest x-ray. I should have an x-ray of my foot, of my ankle, of my lower leg. So that's where you've got to have the correct clinical information to back up the need for that test. All right, so let's talk a little bit more about Joint Commission and their documentation requirements. So as a body that surveys most hospitals, Joint Commission standards regarding documentation merit attention. So you got to pay attention to what they're asking for because they will go through those medical records with a fine-tooth comb. So Joint Commission has transitioned itself to accommodate the changes in healthcare that have taken place since the turn of the century. What are we talking about? We're talking about paper moving to electronic. You have your documentation now managed, stored, and transmitted electronically, and they have to kind of change with the times and be able to kind of roll with the punches just like the facilities do. So now there's major areas that they're looking at. They're looking at management of information, continuity of information management process, the privacy of the information, security and integrity, and then the management of the collection of the health information, retrieval, dissemination, and transmission in usable formats, the ability of knowledge-based information resources, and maintenance of accurate health information. And so most of that is going to be covered in the information management section of the Joint Commission manual. You also have the other sections where you're going to find those relevant Joint Commission standards. They're going to be in the record of care, treatment, and services chapter, and they're going to be in the provision of care, treatment, and services chapter as well. All right, so we talked about those, management of information. Now, let's go over, so we're going to skip a page over to page 39. We're skipping this figure, but this is just a sample summary list for ambulatory care records found on page 38 and 39. So we're going to skip over down to the section called Other Factors in Hospital Documentation. All right, so documentation in the hospital setting also is important because of its role determining the level of physician service provided. The level of service determines the appropriate code, which we've talked about coding, which determines the physician's reimbursement. The issue is particularly important in teaching hospitals in which residents, as part of their graduate medical education, participate with teaching physicians and caring for patients. The Code of Federal Regulations contains the basic rules that regulate Medicare payments to teaching physicians, and how these rules are applied is explained in the Medicare Claims Processing Manual. Most teaching hospitals pay residents a salary, to which Medicare contributes through indirect medical education allowances. In such a situation, a professional service performed by a resident is not paid on a fee-for-service basis, but rather a teaching physician who is present during the service may bill Medicare. So your residents are not billing to Medicare. Medicare has funds for education services to hospitals, but your teaching physician, they can bill Medicare when documentation indicates that they were present and participating in that patient's care. All right, so let's talk about the charge masters. We're skipping over. Again, I'm hitting the highlights, so you be sure to read this chapter. All right, so we're skipping over to the reimbursement chapter or reimbursement section on page 40. And we're talking about hospital charge masters or charge description masters. So all billable services in a hospital are cataloged in a computerized data table called the charge master or the charge description master. Services include procedures performed by nursing and other professional staff, room and board charges, ancillary services such as laboratory testing and radiological imaging, drugs, medical equipment, and supplies used in the care of the patient. And the CDM data table stores elements of each item, and these are listed here in our slides. We're talking about the description of the item, used across hospital services spectrum, a numerical key, a corresponding CPT code, the number of units or other unit of measure, a location code if the item is specific to a particular area within the hospital, and a revenue code to associate the charge with a service area for revenue generation and the assigned price. The CDM serves as a key document in negotiating reimbursement for hospital services during contract negotiations and is the reference point for any reimbursement that is based on a percent of charges. Whereas hospital inpatient services require medical coders to review and code the patient's stay, hospital outpatient services often are coded straight from the charge description master by using the CPT code assigned to the item. This automated coding practice is used most frequently for billing your ancillary services. Annual maintenance of the CDM is recommended for most facilities to ensure that the table is updated to include all current services and to reflect accurate pricing and the CPT coding for each item. So if you didn't negotiate, with anyone on those prices, or you didn't keep up with the times and increase your prices, and let's say you were only charging $75 for a test, but all other hospitals were charging $125, then you're kind of losing out there. So it's very good to make sure that CDM is updated annually at least. All right, so let's talk about Medicare. And we're going to talk about Medicare in the aspect of how it, kind of pays for insurance for patients. All right, so Medicare, we know, is a federal program, and it pays for health care for American citizens that are 65 or older, or citizens with certain disabilities. So if you have end-stage renal disease or ALS, then you should receive Medicare. So payments to hospitals fall under Part A of Medicare, and payments for physician services fall under Part B. CMS contracts with private organizations that handle the claims processing and payments for the Medicare program in a given region. And in the past, Part A used a fiscal intermediary. And a fiscal intermediary was an organization with a contract with CMS to process and pay Part A Medicare claims. And then the Medicare carrier was who paid and processed the Medicare Part B claims. Well, in 2003, all of this changed with the Medicare Prescription Drug Improvement and Modernization Act. They replaced these contractors, your fiscal intermediaries and your Medicare carriers, with MACs, Medicare Administrative Contractors. So that's just some information for you to know. You can continue to read that section. All right, so going on to hospital reimbursement. Page 42. Now, this is going to get in depth, so again, you better read this chapter. Read. So, Medicare reimburses hospitals for inpatient care under the Hospital Inpatient Prospective Payment System. You'll hear this called IPPS, Inpatient Prospective Payment System. Then you have your OPPS, your Outpatient Prospective Payment System. Now, inpatients are paid per case according to a diagnostic related group. Now, you're going to learn much more about that when you get into coding and when you get into reimbursement methodologies. Your last semester, your first semester of sophomore year and second semester. So prior to 2007, there were 538 DRGs that grouped patients according to diagnosis, expected resource consumption, and other characteristics. But in 2007, CMS replaced these DRGs with 745 Medicare severity DRGs. You hear these called MSDRGs. But they realized that, and I don't think it's in this section, but they realized that those Medicare DRGs didn't necessarily fit all patients. And so we're going to talk about our 3M and how they come up with the all patient refined DRGs, and that's going to be over on page 44. All right, so we're skipping down to 72-hour rule. It's at the bottom of page 42. I don't know if any of you have ever heard about the 72-hour rule, but it is kind of a pain in the butt. When a hospital provides services to the Medicare patient as an outpatient within 72 hours before a related inpatient admission. So I go to my physician on a Monday, and I'm coughing my head off, just coughing. And then I get admitted to the hospital Wednesday with pneumonia or something respiratory related. Those two services, the outpatient visit to my physician and the inpatient admission to the hospital, they have to be billed together. They cannot be billed separately if they are related. So this is what's called the 72-hour rule. If I've been seen as an outpatient and then admitted as an inpatient within 72 hours, the outpatient diagnosis and procedures must be coded and submitted with the inpatient bill. And because some hospital admissions occur unexpectedly within 72 hours after outpatient treatment, hospitals inadvertently have submitted both bills. And in these cases, they're in violation of that 72-hour rule. Medicare requires hospitals to implement systems to avoid submitting separate bills for outpatients admitted to inpatient status within that 72-hour window. And if you don't comply, then there could be financial penalties. All right, dropping down to that next paragraph. In 2015, the OIG shifted the focus of review for appropriateness of outpatient services billed under the IPPS to review the admission status for patients whose admission for acute services spanned less than 2 days. So the 2 midnight rule, or 2 midnight policy, emphasizes that patients whose level of acuity requires treatment for less than 2 days should be billed as outpatients. The policy is intended to force physicians to carefully consider the need for an inpatient stay and create a cost savings for Medicare by channeling lower acuity patients to outpatient care. So, the intent is for Medicare to save money, not for anybody else to really get any benefit for that. Because if they're an outpatient, they could still be in the hospital for over 2 midnights. It just depends on, exactly what's going on. So the hospital gets much less reimbursement if the patient is in an observation status instead of that inpatient status. So again, Medicare cost savings. All right, so here's where we're going to talk about those Medicare severity diagnostic related groups. So they recognize that it was not formulated for billing patients outside of the Medicare scope. So during the 90s, the 3M Clinical and Economic Research Department, the Children's Hospital Association, and several physician groups worked collaboratively to create an all-patient refined DRG, or an APR DRG. Whereas CMS MSDRGs focused on the Medicare population, the 3M APR DRGs classify acute care patients and are designed specifically to adjust data for severity of illness, which is how sick is the patient, and the risk of mortality. How likely is it that the patient will die? So those two are really big in your APR DRGs. The severity of illness, or SI, and the risk of mortality, RM. The APR DRG methodology is commonly used to bill inpatient stays for Medicaid beneficiaries and predominantly include your pediatric and obstetrical patients. All right, moving down to the bottom of page 44, jumping back to that outpatient prospective payment system. So the basic units of payment in Medicare's hospital outpatient prospective payment system is known as ambulatory payment classifications, or your APCs. The APC system, implemented in the year 2000, established groups of outpatient procedures and services with similar clinical characteristics and similar cost. One major difference between APC and the DRG system is that outpatients can be assigned more than one APC per encounter, whereas an inpatient is assigned only one DRG per hospital stay. So there's an example on the top of 45 that we're going to look at. So emergency department patient comes in, and it includes evaluation and management, x-rays, and a procedure. In such a case, as many as 3 APCs may be generated. One APC for the evaluation and management, a second APC for the x-rays, and a third APC for the procedure. So that's how it works. But again, you can have more than one APC per visit, but if you're an inpatient, you're only going to be in one DRG. All right, so let's go over to page 46. Medical visits in a hospital clinic or emergency department are classified and paid according to level of service based on evaluation and management coding. In determining the level of service of an encounter, hospitals have developed their own criteria for assigning the E&M codes and have not followed the same guidelines as physicians. So there could be some issues there. Dropping down to the next paragraph. In 2008, CMS implemented composite APCs for certain categories of encounter-based hospital outpatient services. These composite APCs allow only a single payment for certain common combination services provided on the same date of service. For example, if you go into the emergency department and then you're put into observation services, then that's going to be combined into one APC, the Extended Assessment and Management Composite APC. Dropping down, another change related to observation services is that CMS no longer requires specific diagnosis criteria. In the past, you had to either have chest pain or asthma or congestive heart failure or a certain specific diagnosis to be put into observation. And so now there's a separate code that must be used for billing observation services. All related services provided to the patient, including specified visit or evaluation and management codes, should be coded in addition to the observation code. And a written order from the physician is required for the admission to observation care. All right, so let's talk about pass-through payments over on the top of 47. The OPPS allows additional payments to cover the cost of innovative medical devices, drugs, and biologicals. Called pass-through payments, these categories provide separate payments in addition to the regular APC payment. Payments for a given drug, device, or biological can be made on a pass-through basis for 2 to 3 years. All right, provider-based clinics. Hospital-based clinics are considered to be provider-based clinics under the OPPS. When a Medicare patient is seen in a hospital-based clinic, the clinic receives an APC payment and the physician receives a reduced payment for his or her services because there's no practice expense. It's been shifted to the hospital. And the total of the two payments is greater than the full fee schedule payment that a physician in a freestanding clinic would receive. So at the bottom of that section, it is important to remember that the details of the OPPS change annually. To obtain the most current information, the Health Information Manager should consult the latest regulations at the CMS or Federal Register websites. All right, we're going to talk about long-term care prospective payment system. So since October 1 of 2002, Medicare payments to long-term care hospitals have been determined by a diagnostic related group. Although the numbers and titles of most of the Medicare severity long-term care diagnostic related groups are similar to those of inpatient MSDRGs, the LTC DRGs differ from the inpatient DRGs in relative weights and their associated lengths of stay. LTC DRGs are also similar to inpatient DRGs in that they are based on a patient's principal diagnosis additional diagnosis, and procedures performed during the stay, age, sex, and the discharge status. Moving over to page 49. Medicare has developed specific rules to discourage the transfer of patients between the LTAC and other facilities for financial rather than clinical reasons. And so there's 3 payment mechanisms to address this issue. One is the concept of the interrupted stay. This applies to transfers to and from an acute care hospital, inpatient rehab facility, or a skilled nursing facility. In the case of a patient who is discharged to one of these facilities and is readmitted to the same LTAC within a certain number of days, the LTAC episode is considered as one interrupted stay, and the LTAC receives only one MS LTC DRG payment rather than 2. Another mechanism is the 5% rule, which applies only to transfers to and from a collocated facility, such as a hospital within a hospital or a satellite facility. After 5% of all discharges for the fiscal year are made up of transfers from the LTCH to the collocated facility and back, these cases are paid as one LTAC admission rather than 2, regardless of the number of days of the intervening stay. All right, let's get into other reimbursement issues, other payers. Other payers may pay for hospital outpatient care under a variety of systems. Traditional indemnity insurance plans pay the usual, customary, and reasonable charges of the hospital. However, fewer patients are enrolled in a pure indemnity type of plan. Generally, patients have incentives to use the services of a provider who has agreed not to exceed certain limits on charges. Billing. Let's talk about billing. The uniform bill, which is called a UB04, or a HCFA 1450, or the CMS 1450, is the standard form for submitting information to third-party payers when filing claims for hospital services. And you see a figure of that in 2.4 on the next page, page 50. That's an example of a UB04. In 2007, the National Uniform Billing Committee updated the form to accommodate more diagnosis and procedure codes in anticipation of the implementation of ICD-10 CM and ICD-10 PCS. And the health insurance reform modifications to the HIPAA Electronic Transform Standards Final Rule, published on January 16, 2009, implemented the current version of the 5010, accommodating the longer alphanumeric ICD-10 codes in preparation for the implementation as well. And the revised form also meets electronic data standards and allows for present on admission indicators as well as national provider identifiers. Under HIPAA, physicians use the CMS 1500 form for submitting claims. This revised form allows for national provider identifier reporting, and the use of paper bills and claim forms is diminishing. Electronic transmission of claims is the norm for both hospital and physician claim submission. All right, so we're going to cut off here and we're going to pick up with coding and classification on another lecture.